Can everybody see it?
Yeah, that looks perfect.
Okay, great. All right, guys. So like Jackie said, if I haven't met you, it's Krystle Hernandez. I'm one of the hospitalists, and today we're going to talk about high value care. And I took this, I adapted this presentation from the ACP curriculum that kind of spans about 6 hours of materials, but I kind of put together what I think is high value, high yield for all of you, and also kind of focuses on hospital medicine, since that's where you'll find me. Okay, so our focus will be on eliminating healthcare waste and over-ordering of tests. We'll talk about high-value hospitalizations, overcoming barriers to high-value care, and high-value care quality improvement. So it is actually very well tied in the survey that one of your PGY2s, what Madeline is doing. So first, we're going to talk about eliminating healthcare waste and over-ordering of tests. We're going to define and articulate the importance of high-value care, discuss the cost implications of several common clinical scenarios, and the evidence-based guidelines for appropriate diagnosis and treatment. We'll identify clinical reasoning and tools to assist in management of uncertainty. So high-value care is the relationship or the ratio between quality and cost, quality being the benefit to the patient and cost being the financial and non-financial costs to a patient, so like the harms. Or high-value care is achieved when the benefit is high and the cost is low. And so why care about costs now? So this is a graph of the healthcare spending as percentage of GDP. So as we can see, steadily rising, a lot more in the last few years, and 1 in 3 healthcare dollars are waste. And despite being first in the in spending among wealthy nations, the U.S. has the highest infant mortality, child mortality, maternal mortality, and rates of preventable deaths. So while we spend the most, we might not be providing our patients with the best care. And where do we see our sources of excess costs in healthcare? They're in the areas of misprevention, fraud, inflated prices, inefficient delivery, excess admin costs, unnecessary services. And we could spend time and think about what are the examples of each of these, but I'm sure many things come to mind. So while not all excess healthcare costs come from the docs, come from us, a lot of it does. And so 53%, as per this study, is related to physician-driven waste. And so what are the areas that we impact the excess healthcare costs? So that's in unnecessary services like labs and imaging, which we will talk a lot about today, inefficient service delivery, and missed prevention. Okay. So do we overorder tests, and what's the quality to cost ratio for these decisions? So this will be an interactive hour. So can someone tell me why I put together this kind of unattractive collage of blurry screenshots?
Debbie and Martin, I see you studying it closely.
They're week-long labs.
I think with this, I also rotated with Dr. Hernandez before. I think, yeah, I think it's very important that we check the labs of our patients that we request on a daily basis. I know that there's a selection in the admission part wherein we can order for tests for like how many days, for like certain number of days. So sometimes even if it's not relevant for the for the management of the patient in the hospital, we forget to edit the order to like daily or every other day, because sometimes it doesn't really change the course of the patient in the hospital. Also, sometimes there are certain tests that we order repeatedly without checking. We can see in this, like in this one of the pictures here, that CBC, CRP, VBG, ferritin were ordered multiple times. So it's very important that if we are pre-charting in the morning, we should check the orders and just discontinue or remove some of the orders that are doubled or tripled in the orders. Yeah.
Yeah, exactly. So anybody who has rotated with me would know that I give a mini version of this spiel. So, I mainly, these pictures are to highlight the areas that we're ordering labs repeatedly for every day for 1 week. And sometimes you'll see 2 orders of a BMP, or as you can see here, a BMP and a CMP ordered for the same period of time. That's obviously repetitive, and so we can see areas where there are wastes of cost. There are unnecessary sticking to the patient, which affects their health and their experience. And also, like, the concept that every patient, we have caps on how many patients we see, because we think about every one of our patients every day. And one of those things is what we are going to do to them, right? So the sticking of labs is one of the things that, or obtaining labs is one of the things that we think about for our patients every day. So I also thought that this one is kind of a very recent one I saw I took a screenshot of last month when I was reviewing one of our patients, every 72 hours for 6 occurrences. And I guess the CMP was an error where it said every 72 hours for 6 weeks. I hope we're not keeping that patient there for 6 weeks. So it's obvious to a typo, but still, they meant 6 occurrences, which to me still means is still too much, because if you think your patient is stable enough that they're not getting labs every day, then we should also be thinking about when we should get them, not just automatically ordering them for 72 hours. Okay, so why do residents overorder tests? And I'm sure, and the reasons residents overorder tests are the same reasons that attendings overorder tests, but what are they? Why do we do it?
Jasmine saying in the chat, defensive medicine.
Okay. What else?
I would say laziness as well. It's much easier to put in everything for a week and not have to check it daily.
Yeah. I can't see the chat, so if anything else coming exciting through there?
Not yet.
Not yet. Okay. So let's see. So why do we overorder tests, or and well, we just talked about labs. So discomfort with diagnostic uncertainty, lack of knowledge of costs and harms, no training in weighing the benefit relative to costs and harm. There might be a desire to be complete. The preemptive ordering, because it's easy to say like Jackie, like laziness or not wanting to think about it, but also because we're rushing, we're stressed, it's one thing that we can check off our list, right? Unnecessary duplication of tasks, ease of access to services while inpatient, duplicating model behavior, right? Faculty demand, you think you're attending, or sometimes they want it, right? Defensive medicine, as you guys said, and patient requests, right? I often use the excuse that your patients don't want to be stuck, but sometimes some of them do. So that can also play into a factor. So a call to action. So physicians must lead in addressing these problems. 3 in 4 physicians say over ordering of tests and procedures is a very or somewhat serious problem. 58% think physicians are in the best position to address problems of unnecessary testing and procedures, and trainees must be at the front lines, right? And so I just wanted to put in a plug for the Choosing Wisely campaign, which is put forth by the ABIM, and it really has some great information about high value care. It's unfortunately, we don't have enough time to go into it, but the Choosing Wisely, if you round me, I might mention also the Choosing Wisely, like the Things We Do for No Reason series, which I think is great. Talks about things like ordering, why do we order urine lights every time someone's an AKI, or a Doppler every time someone comes within with a simple cellulitis, right? When we know that that really doesn't provide high benefit to our patients. Okay, so practicing high value care does aims to improve patient experience of care. It improves health of our population, reduces per capita costs of care, and improves clinician experience. And the steps towards high value care that we will touch upon today is understanding the benefits, harms, and relative costs of interventions, decreasing or eliminating interventions that provide no benefits and or may be harmful, choose interventions in care settings to maximize benefits, minimize harms, and reduce costs, customize a care plan that incorporates patient values and concerns, and identify system level opportunities to improve outcomes and minimize harms and reduce waste. Okay, so we'll talk a little bit about case. And so Mr. B is a 57-year-old man currently admitted for suspected pneumonia. His chart indicates he had been previously diagnosed and treated for C. diff 3 months ago. Currently, he has no abdominal complaints, normal stools, febrile to 101, normal tensive, non-tachycardic. His white blood cell count is 13.5. X-ray shows right lower lobe infiltrate, and your sepsis order set includes a full infectious workup, and you are debating whether to send C. diff testing. Okay, so while this example isn't necessarily that pertinent to our hospital, because you got to jump through many hoops to order C. diff, I think it's important concept to walk through. So how strong is your suspicion he has an active C. diff infection? What are your options for further workup? How will a positive test change your management? What is your threshold for treatment? So what do you guys think about this case and sending C. diff? The C. diff PCR, I mean.
I think it is warranted. He has a fever, he's had antibiotics. Didn't see any belly pain, but I think it's reasonable.
Okay. Anybody else?
I guess like he's not having symptoms like normal stools. We have a reason for why he has a pneumonia. So there's not anything pointing to him having like an active C. diff infection.
Okay. All right. So very good. So 2 points of view. So when we're ordering a test, so based on the clinical presentation of a person who meets SIRS criteria, but clinically has another reason for infection, we want to think about, is our diagnostic uncertainty so high that we want to get tests to confirm our thoughts, or do we think that there's another reason that like maybe some tests more in the respiratory system, because that's what symptoms are more obvious, right? So in this case, like when we're thinking about a C. diff PCR, we want to think about, again, high value care is the quality, which is the benefit to the patient over the cost. So what would a positive or negative test benefit to the patient, right? So a negative test would only solidify or deter like what we already think, that it's probably not C. diff and it's something else based on symptoms. And a positive test would put us in the position, would still not explain what the main presentation of this person's illness. So probably the benefit to sending this test in this particular case would be low. So because and so therefore, if the benefit or the quality of the test, the benefit of to the patient is low, then the value to the patient would likely be low. So understanding the benefits, harms, and relative costs to of the intervention. So how much do you think the patient will be billed for the C. diff PCR? How much does 10 days of oral metronidazole vanc cost? What are the potential downstream costs if the test is positive? And by costs, meaning like not just money, but what that means for the patient. So let's keep those all in mind as we go through the case. Sputum culture was negative, but the rapid viral panel was positive for human metapneumovirus. So you suspect the viral pneumonia was the cause of his symptoms and x-rays findings. The stool C. diff assay was positive, so the patient was given flagyl or metronidazole and discharged home. At home, he developed severe nausea from the flagyl and returned to the emergency room. And he's rehydrated with IV fluid, switched to oral vanc at times 10 days. And so the overall cost, right, we could see here, how much does the PCR cost, the antibiotics, him having to come back, having to switch to PO vanc, and all for, we're not really sure why, because he probably had this viral illness because of a metapneumovirus, and that's why he had a fever, right? So when we are looking at this case, we're going over the benefits and harms and relative costs, the decrease of trying to decrease or eliminate interventions that provide no benefit, and choosing interventions and care settings to maximize benefit, minimize harm, and reduce costs. So how do we decrease, how would we decrease or eliminate interventions in this case if we were to encounter it? It's about, we have to know our stuff, right? So avoiding testing, and we can find that again with another plug for choosing wisely, and also looking at the guidelines. So the IDSA guidelines really do recommend avoiding testing for C. diff infection in the absence of diarrhea. In the absence of diarrhea, the toxin in the stool would indicate a carrier status and should not be treated. So so this is, kind of this evidence probably has led to why there has been kind of system initiatives to, as I joked earlier, jump through hoops to get C. diff, because testing in our patients. And while we sometimes are frustrated with it when we really do have a higher suspicion, we probably are also preventing a lot of unnecessary testing. So do you have a case where you feel like you overorder diagnostic testing? Do you think that happens in our institution a lot? I mean, I think it happens just as often as it does in other places. And, we always have areas to improve. But like I said, the C. diff example probably we don't encounter as much. So every time, you know, so next we're going to talk a little bit about diagnostic uncertainty and how that plays in high value care that we can deliver to our patients. So when we see a patient, we assess the patient, formulate an initial diagnostic hypothesis, and if there's low confidence, we pursue testing. If it's high confidence, we initiate treatment. So there's a study of internist attitudes towards uncertainty and patient charges in a primary clinic. And we see that uncertainty increases resource use. Increased physician anxiety due to uncertainty and increased concern about disclosing uncertainty to patients translates into higher charges. Each standard deviation of change in uncertainty scale corresponded to a change of mean of charges of between 5 and 17%. So it's important that we assess additional tests, additional testing without using the value equation we talked about value, quality, and cost relationship. Will it influence management? Always thinking about downstream effects, harms, and costs to our patients, and how are other, what are things that we can do when we do have diagnostic uncertainty and we want to test more, and we pause and we think about whether or not our testing is going to be helpful. What are other ways, what are strategies that we can use? So we can use things like clinical decision-making tools that have kind of been tested, right? So just like the PESI score for PEs, or the pneumonia severity score, the curve 65 for pneumonia management. Then you can also, so using scores and tools, we can also use our the rest of our team, right? Specialists, you're working with an attending or resident, your colleagues, and clinical observation of the patient, how watching them over time, how that can affect your decision. So using some of those, keeping some of those strategies in mind, we can talk about a 23-year-old woman with no past medical history presenting with acute onset colicky right flank pain. Her exam is afebrile, tachycardic, moderate distress, CVA tenderness. Labs show mild leukocytosis. Urine dip shows trace leukocytes, trace blood, cultures are pending, and you're thinking about pyelonephritis versus urolithiasis, and want to confirm what imaging, if any, do you want to order. So you might be thinking, so if you guys ever, when you're ordering a CAT scan, there's always that kind of view with where there's like a bunch of numbers, and it says usually you might see this scale where it says usually not appropriate, sometimes appropriate, or usually appropriate for a particular indication, right? So that's the one of the appropriateness, like the rate appropriateness criteria put by the American College of Radiology. And so if we're thinking about a patient who we either could have a UTI or kidney stone, the best test that we know about for the kidney stone is the CT abdomen pelvis without IV contrast. And so we can use some of these support tools that kind of pop up all around us when we're ordering an Epic and things like that, and talking about in rounds. But these support tools are only helpful when they are referring to similar population. Sensitivity must be high for high risk conditions. And you can only use it as a supplement, not in place of clinical judgment. So in this particular case, we did an X-ray of the abdomen was performed, was non-diagnostic. The patient was treated empirically for UTI while awaiting urine culture, continued to have pain, urine output was decreased. A renal ultrasound was performed, a hydronephrosis was identified, and then the patient went for the CT and then found to have an obstructing renal calculus, and then urology took over. Okay, so we saw that in this hospitalization, we can see that these would be like kind of the average cost, seeing that the CT abdomen pelvis much higher in cost than the X-ray or the ultrasound, but most helpful, right? So, and so in this particular case, it kind of points out how high cost doesn't mean low value, right? And that low cost doesn't necessarily mean high value. So in this case, maybe you went for the X-ray because you thought you could see the kidney stone, but you didn't, and so probably the ultrasound wasn't really necessary. We need another intermediately rated test. So if the first lower yield test doesn't work, then maybe we could have cut out one step here and gone straight to CAT scan. And so we can see that high cost interventions may provide good value if highly beneficial, like in this case, and low cost interventions may have little or no value to benefit and increase downstream costs and to the patient. So healthcare waste is an urgent and multi-billion-dollar problem. Every provider must carefully weigh costs, harms, and benefits, and order only those interventions that add value to patients' care. System level interventions to support high value decision making are critical, and diagnostic uncertainty is a major driver of waste. And so we can talk a lot over testing. So now moving into what makes a high value hospitalization, we can compare charges for inpatient and outpatient services, appreciate how delayed diagnosis and diagnostic errors increase costs by extending hospitalizations and increasing morbidity and mortality. We can recognize the out-of-pocket costs associated with different types of hospital discharge, and optimized medication reconciliation as a key component of safe transitions. Three areas of hospitalization or providing high value care during the hospitalization process would be before pre-hospitalization, which the admission decision, which doesn't necessarily isn't always, I mean, we don't have as much control over, but still something we should know about and think about. The management and at discharge, also very important, and something I talk about a lot during my rounds too. So in this case, we have a 68-year-old man with a history of controlled hypertension who presents to clinic today, complaining of fever, right lower extremity pain, and redness. He is afebrile, vitals are otherwise stable, and he appears comfortable at rest. He is notable for tender right lower extremity with erythema, warmth, edema, and extending from the ankle to the mid-calf with no obvious portal of entry. So when we are confronted with this situation, we think, would you manage this patient as an outpatient or recommend admission to the hospital? What labs or exam findings would influence your decision? And what system level interventions could you consider to improve recognition and management of patients with cellulitis? So in this patient, we think about like our biggest tool we can use is like what we know cellulitis should look like, visual support tools. So we know that, if it, looks like a duck and it quacks like a duck, it's probably a duck. And so we have to just treat it like it is and treat it like it's cellulitis. But if it looks like a duck and maybe doesn't quite sound like quack like a duck, we have to think cellulitis, but also make sure to think about other options. And if it has nothing to do with cellulitis, it's probably not cellulitis, right? So it's very rare, for example, to see bilateral lower extremity cellulitis. So it's, it's probably, if that was the case, then it would probably not be that. So we can provide high value care by using our knowledge and what we know, matches illness narratives that we've studied and created in our mind and have filed back away in our in our heads. Okay, so we when we're confronted with this decision, we think about aspects of how this cellulitis may be serious and need inpatient admission. Does it need IV antibiotics? Does this person have comorbid conditions? So in this case, I think the extent of this patient's infection maybe could be might benefit from some inpatient stay. So, but when we do make that decision, we have to see what the costs are to the patient, right? So outpatient management versus inpatient management, as we can see in this chart, is a huge difference, right? So sending CRP outpatient versus inpatient, just probably because of like the turnaround time and probably, you know, an ER charge, actually like the bed, the hospital bed. So the total care would outpatient versus inpatient is multiple times larger in the inpatient. This patient was in fact admitted, right? Came into the RD and was admitted. They got antibiotics for they and improved, and then they weren't febrile again or anything, but he comes back to the ED complaining of right lower extremity pain and swelling and denies fevers at home. He's afebrile this time, vitals BP 110/60, slightly tachycardic 105, and we see that the O2 sat is 98% on room air. He has right lower extremity edema to the knee and erythema, and he's readmitted for recurrent cellulitis. And while he's in the hospital, he develops dyspnea, he gets an oxygen requirement. They do a CT PE protocol, and they see that he has a new PE, and he has an ultrasound that has a right lower extremity TVT, acute TVT, and he's starting enoxaparin. So we use our clinical diagnosis to provide our leading diagnosis for the patient, but there was in fact like an error, right? We can see, and this is also something that plays into high value care. How do we avoid making diagnostic errors without using million-dollar tests? And it's really about being aware of some of the things that causes diagnostic errors, right? And in this case, it may have been a bias. What do you think in this case led to the patient's delayed diagnosis? Did they have any biases? Did we have any biases towards the patient? Have you experienced any errors in diagnosis that led to patient harm in your own personal practice? So in this particular case, we saw that maybe the diagnostic error wasn't just kind of cognitive, in the sense that there's probably there were probably some biases in our approach, because the patient was a readmission for cellulitis. We immediately thought cellulitis. So it's really, and so we kind of fell into this hole of fixating on a single feature of a case, just like a repeat of the right leg redness, but not seeing that it wasn't like the last time. It wasn't associated with infectious symptoms. And so we need to just kind of pause. Like that's another area of high value care that we have to work on and develop insight and awareness of our thinking processes, and and like I said, just making sure to kind of check ourselves and each other as a team. That's why we take care of patients, not just one person, but many people. And another area of the hospitalization that want to talk about is discharging. So this patient, very typical of something we might see. So initially came in for cellulitis, complicated by a DVT. They come, we find out that the cultures eventually will come back, blood cultures will eventually come back positive for Staph aureus, uncomplicated, but will require 6 weeks of IV vanc, and then the patient is ready for discharge. And so we're all ready to set up that DBN. And then we find out that our patient lives in the with his husband and elderly mother-in-law and a third floor walk-up. So we then find out that they're in another area that we need to look at. Will this patient be discharged home versus any of these other options, and then kind of the cost that goes along with that. All important, and plays a large factor in like the overall care that we provide for our patients. Like, can they handle this? Like, if they had the choice and one option, they could pick the home option with good support. Is that better for them than going to a skilled nursing facility? As far as their, finances are concerned, those are all things that we aren't necessarily our priority, but are important for the patients, and it's important for us to be comfortable with talking about those topics with our patients, and knowing that those weigh heavily on them. And so that's one area of, like their hospitalization that we kind of brush off, but maybe just have to be more aware of. And then another area of patients' hospitalization and discharge that we can kind of take a more front seat in controlling is at discharge, this healthcare provider used the electronic medical record to carry forward all of Mr. J's hospital medications to the discharge medication list. What are potential sources of error, harm, or waste that may ensue? So I want to pause here because I've been doing a lot of talking and see if this part of a patient's hospitalization, if you think that there are areas that we can improve upon as far as med rec is concerned, right? So discuss a personal experience where you saw a patient affected by inadequate medication reconciliation. I'll just, for the sake of time, I'll share a quick story about how when I was in residency, one of my one of my co-residents discharged a patient that without continuing their AEDs, their seizure meds, and they went to a SAR. So then that patient was readmitted a few days later after having a pretty bad grand mal seizure. So the med rec is super important and something I talk about way too much in my rounds. But what are ways that we can, as doctors, preparing our patients for discharge, do a better job of med recking or prepping our patients? What are some strategies you think we could implement? Or areas you can improve?
I find that just talking to your patients a few times is very helpful. So rather than just getting a piece of paper that tells what's going to go on, the day before, 2 days before, kind of start letting them know what's going to happen, because then they start to digest it. Then they have questions for you when you're actually discharging them. Because if not, they get a piece of paper, they don't really read it, and then they get home and then they're confused.
That is an excellent suggestion, and something that we definitely changes a patient's outcome, right? Because we spend a lot of time in that doc room changing this and changing that, and if we can kind of turn patients' whole worlds upside down if they have their meds all lined up at home, ready for them. And so if we make changes, we need to talk to them, right? that increases their likelihood to adhere to the regimen, and also decreases likelihood of medication errors. Yep. What else?
I feel involving family is also very important, especially if the patient is elderly, frail, lives by himself. Calling daughter or son who can get involved with getting his medication on board is also very important, or wife or husband, whoever lives with the patient.
Huge difference. Yep. Agreed.
You can also try getting in contact with their PCP. Like we had a patient who lives alone and so doesn't have anyone at home who helps him with his meds or who could take a photo of his meds, etc. And he just changed pharmacies, so we couldn't call his pharmacy, and he didn't know the names of his meds. So the only way we could do it was by reaching out to his PCP and getting an updated list of his medications.
I like it. Anything else?
I think another thing that we can do is to make sure that once the patient was admitted, that all the medications are properly reconciled and reviewed the first few days of the admission, so that nothing will be missed when the patient gets discharged.
Right. So, and that's a huge thing, right? So, med recking on discharge is really dependent on med recking on admission, right? So, I know sometimes you can't do it in the first day, but by the second day, we should really make that a priority for our patients, because sometimes at the end of the admission, you can't go back anymore. Like, it's hard to figure that stuff out. Also, it might play a huge role in the management of the patient during their hospitalization. And so when you are med recking, so on admission and at discharge, you should be always asking those questions like, why is the patient taking this med? Do they still need to be on it? Do I know why they're on it? And do they know why they're on it, right? So those are the things that all those points we should be hitting. Excellent. Okay. So just in summary, so inpatient charges are usually greater than outpatient charges, as we know. Use the inpatient setting only when necessary. Delays in diagnosis and diagnostic errors, add hospital days, lead to readmissions and morbidity, mortality. Different discharge scenarios have different pocket costs for individual patients. Consider these as your plan for safe discharge. Thorough medication rec should be performed at every outpatient visit and prior to every hospitalization, hospital admission and discharge. Okay, so what we talked about, you guys all know all those things, and we would love, and I'm sure everybody listening to this knows like that they want to be able to provide that to all of their patients, but sometimes it's difficult. And why is it difficult? And how can we overcome those barriers to high value care, right? So identifying the potential barriers to delivering high value care. Why don't we do that? Why can't we do everything we just said all the time? And sometimes that's because of a lack of guidelines, because of time pressure, lack of centrally available information on the local culture might play a role, lack of time to explain to patients, poor familiarity with what's going on. If you're not comfortable with with what you're going to talk to your patients about, you're unlikely to talk to them. Discomfort with diagnostic uncertainty, lack of appreciation of harms, and lack of knowledge. And again, defensive medicine comes up, right? So what are some of the barriers to providing high value care? Defensive medicine is something that might come up because we think that more care is better care, but that's not true. And high value care does, and defensive medicine does not protect against malpractice, right? Malpractice claims are typically arbitrary and hard to prevent, and 40% of the time don't even involve a medical error. And so providing more care isn't better care, as tests and treatments have associated harms. And lack of follow-up of abnormal tests often leads to malpractice litigation. Don't order tests if you don't plan on following it up and acting on the results, because that actually puts you more at risk, right? For your liability. And some other barriers, that we can overcome by listening to our patients, making a plan that revolves around them, documenting carefully. But it's really often difficult with our patients' expectations, because sometimes patients often think more testing is better. So having to spend all that time to explain to them why maybe that might not be the case. You often struggle with patient satisfaction, and trying to give your patients clear answers, rather than and minimizing the uncertainty for them. And the main way that we can kind of overcome that barrier or overcome that obstacle is really towards like patient-centered discussions and using your whole team to help patients' understandings of what's going on. And using plain language and things that we all know, but take a lot of time. And then I think one other area that I think has a nice example is of why we sometimes have a barrier to healthcare providing high value care is in the area of is in terms of the local culture. So you're an intern on the general medical service. You are admitted for C. diff, colitis, confirmed by PCR and seen on CT abdomen. On hospital day 3, the patient was worsening abdominal pain and distension. Her abdominal exam has worsened and is now tense with rebound tenderness, and urine output has dropped off precipitously. You are concerned that the patient has developed an acute abdomen. You call the surgery resident and ask for a consult for worsening C. diff, concern for perforation. She says, order a CT and she'll get back to you this afternoon. You don't think that's appropriate. What's the disconnect? What about, think about both your perspective and and that of the surgery resident. What would be the high value care choice for this patient? How could you better frame a question for the consult? So what do you guys think was why do you think the surgery consult resident answered that way? And how do you think you could get a better or different outcome or improved outcome?
I think the surgical resident is probably busy, has a lot of stuff going on, other consults. So maybe appropriately expressing your concern for the patient, emphasizing on the abdominal exam. Maybe that can get her to, or mention labs. Maybe she has worsening leukocytosis or other concerning signs that would encourage the consultant to evaluate the patient before recommending a CT.
So a little bit vague, the consult, right? So you said the abdominal findings, maybe vitals or labs. Yeah. Anything else? How else would you approach it?
I think the one way of framing a consult is to initially say that we are very, very concerned for this patient, and that this patient's findings in the physical examination of abdominal distension, rebound tenderness, these physical and decreased urine output are very concerning for perforation, and we are very concerned, and we want the patient to be seen immediately.
Excellent. So yeah, using specifics, right? Speak their language, differentiate between an emergent, urgent, or routine consult, ask a specific question, right? You're a doctor, you made some conclusions already, you just need a specific thing answered, and you can often get a better outcome. So offering to see the patient with them at the bedside, things like that, so that you can better relay what's going on. Okay, so summary is that, sometimes we fear we often choose defensive medicine, and that's a big barrier to high value care, as well as patient expectation in the local culture. We can improve that mainly with good communication, and being as clear as possible with whoever we're talking to, whether that be a patient or other doctors. And so kind of very quickly, the high value is making changes in high value care can happen on your personal level, but also at the QI level. And so there's a lot of areas that getting involved in high value care can be really good for our learning at the resident level, for making changes that you might find very rewarding at the hospital level. And it's like many examples of resident-led QI initiatives. I know Madeline is, I think that what she's probably doing the QI project regarding lab stewardship at Mount Sinai West. And so, well, first, this is a QI project that I did in residency. And if for those of you who came back from SGIM and might have seen my face on some poster or some I think a itinerary from some old picture for this is the project that I was presenting at SGIM a few years ago. And so I'm kind of trying to be involved in that again now. And so there is currently a lab stewardship project at Mount Sinai West, but there's also one that at Mount Sinai Morningside that's led by Dr. Faye Reef, and I will be also supporting the initiative. And it's kind of mainly focused around educating about why overuse of labs, like the cost of them, why it might be harmful to patients and their experience and all of that. And the way that the intervention that we're looking to roll out very soon is actually, we created in Epic, we were able to create this tab called the Recurring Labs tab. And so if you guys want to, you can play with it already, put it on your tabs, on your patient list and see. And so I'm not saying that there should never be a check mark, but it's something to think about, right? So if they have a check mark for recurring labs, why do they have that? And kind of educating each other as a team, providing accountability and feedback to each other about that. And so if you want to be involved in that QI project, you can email Dr. Reef or I or me, and we'd love to have you guys get involved. And so, but if that really doesn't interest you, you guys should also know about high value care because it's on the boards. So we can do very quick questions. There's 2 or 3 of them. So if someone wants to read the first question.
Sarah, do you want to volunteer to read?
Sure. So a 50-year-old man is evaluated during a follow-up visit 1 month after being hospitalized for deep venous thrombosis of the right leg. He is no longer taking apixaban because he received only a 14-day supply after leaving the hospital, and his symptoms had improved after finishing the supply. He thought he had finished a course of therapy. On physical examination, vital signs and the remainder of the physical exam are normal. Which of the following steps should be taken now to promote medication adherence? Do you want me to read
Okay. Yeah, you can read the
it? I'm
options.
sorry.
Yeah,
So
okay.
A, patient education, B, recommend a pill box, C, screen for low health literacy, or D, select an anticoagulant with the lowest copayment.
All right, guys. So which one do you think we should do? A, B, C, or D? I'll wait for a couple responses in the chat, or if someone wants to say what they think. All right, so we got the majority of people are saying patient education, And that is correct. So from the stem, you can see that the reason why the patient didn't take it is because they thought when they left the hospital that the 14 days was enough. So probably spending the time, right? Like I always tell them, starting a patient on DOAC is a huge thing that changes their lives in many ways, right? So explaining to them how long they'll need to be on it, on apixaban really will make the difference, and was the reason for the patient's non-compliance in this case, right? So I'll do this one. A 35-year-old woman is evaluated in the emergency department for a second episode of syncope that occurred while standing. She had a prodrome of diaphoresis and nausea with both episodes. After the episodes, she felt tired but not confused, and her exam was normal, EKG normal. So which of the following is the most appropriate management for this patient? Cardiac monitoring, CT head, discharge home, echo. Answers?
So kind
All
of
right, this is,
yeah.
yeah, a little mix. Okay, so this is mix app. Okay, guys. So I know you're multiple answers is not possible, but the this one, sorry, is one. The correct answer is discharge home, and I know that there was a mix because we see syncope patients all the time, and everyone's management is different. And in this case, this young 35-year-old has a very clear picture of vasovagal syncope, and so doesn't require workup. If there were other factors like older age or other comorbidities would play a different role, and that's probably where the mixed answer comes into play. And then I know we're short on time, but I really want to do this question, so I'll do an 84-year-old man is evaluated 3 days after he was admitted to the ICU with a right lower lobe infiltrate and had presumed sepsis. On the day of admission, the patient vomited, aspirated, and developed respiratory distress. In the emergency department, temperature was 100.9, tachypnic, tachycardic, and hypoxemic and hypotension were also present. The chest radiograph on admission showed an infiltrate in the right lower lobe. They're giving IV fluids, oxygen, and broad spectrum antibiotics. And in 24 hours, the patient rapidly improved. And on physical exam now, everything is normal and the white count is normal. Sputum and blood cultures are negative. Which of the following is the most appropriate antibiotic management? Continue for 4 days, additional days, continue for 7 additional days, 10 additional days, and discontinue antibiotics. What's the correct answer? All right. Okay. Yeah. So the again with mixed, because it fights against what we it's a kind of bringing into play what we see on test questions and what we do in real life, right? And how we sometimes are like we do see our barriers to providing high value care, because the right answer in this case is to discontinue antibiotics. I went very quickly through this exam question, but if you slow down and you look at it, you'll see that the patient became acutely ill after an aspiration event and then quickly improved. So therefore, there is no need to treat aspiration pneumonitis or an aspiration event if there are no indications for no evidence for infection. So that is where I kind of wanted to end it and say thank you guys, and sorry I went to the end of the time. Yeah. So
Thank you so much, Dr. Hernandez.